A 13-year-old young boy was referred to us for the favor of endoscopic ultrasound for pancreas mapping, followed by endotherapy for suspected recurrent acute pancreatitis leading to chronic pancreatitis. And as you can see here, in this radial endosonographic examination, I want all of you to pay attention to the pancreatic duct seen in the head of the pancreas region. That's the region of between 7 and 8 o'clock position. You can see the portal vein, the splenic vein, the portal confluence, and you can see the bile duct coming down. What I realize is that very short stack sign could be seen. However, as you can see, I'm able to spot a dilated pancreatic duct, and there is a lot of fibrosis around the duct in the head region. You can see here very clearly. These white markings are severe fibrotic stricturing of the pancreatic duct region, perhaps in the minor papilla. We are dealing with a possibility of some pancreatic ductal anomaly, most likely pancreas divisum, and for inexperienced eyes it might be a little challenging, but it has been our experience since 1999. That was the first time we presented our data at DDW, our ability to pick up pancreas ductal anomaly on EUS. I'm still seeing the dilated pancreatic duct with fibrotic stricture. You can see a dilated PD and it's crossing. And you can see the dilated PD in the genu. When I withdraw the scope, gallbladder is absolutely fine. Actually, this patient was advised cholecystectomy by a few clinicians in Mumbai. However, as we all know, empirical cholecystectomy in recurrent acute pancreatitis does not stand a chance now. It has to be done first. EUS of pancreatic body did not show any change of chronic pancreatitis, but dilated MPD was noted. So here we go. Now we will do pancreatic endotherapy. This is the standard protocol in our unit, that as and when there is a patient of recurrent acute pancreatitis or chronic pancreatitis, and after EUS mapping, if it's required, we go ahead and do endotherapy. As you can see, I tried cannulating the minor papilla, but it's too small, and now I'm cannulating the major papilla. And when you obtain a cholangiopancreatogram, you can see that the bile duct is coming up. A very short pancreatic duct going into the uncinate was seen earlier. So this almost confirms the presence of pancreas divisum. Now the question here is that whenever patient has recurrent acute pancreatitis, the minor papilla opening is extremely tight, and it closes off because of inflammation. And we are using all possible gadgets available in the world to try and opacify the minor papilla, the duct, but it failed. So what we decided to do was freehand minor papilla pre-cut sphincterotomy. You can see I'm cutting from the top-down approach. I'm sure most people would not have experienced or witnessed a freehand technique for minor papilla needle knife pre-cut. We have some experience in our unit. I think we were one of the first few to do this. You can see very pink mucosa epithelial lining, and then you cannulate after deroofing, and there you go. I was able to jump in with the guide wires, a large duct in the body and the tail. You'll see once you get a pancreatogram. We always use a hydrophilic wire. You can see my catheter has gone up, and you can see a few filling defects like concrements and dilated pancreatic duct with dilated side branches. Somehow we managed to push the guide wire. You can see the guide wire going down up to the tail of the pancreas, and it's a dominant stricture in the prepapillary area of the pancreatic duct. with a great effort, we were able to go across and then exchange a stiffer wire. You can see here pancreatic juice has started draining, and immediately then we started dilating with Sohendra dilator. A 7 French dilator was pushed in across the dominant stricture, and we were able to pass a 7 French dilator. Once we had dilated the stricture, the next step was to put 5 French Teflon stent. We always try with 5 French to start with, and we prefer straight stents rather than pigtails in our unit. This is a 8 to 10 centimeters 5 French Teflon stent being inserted in the pancreatic duct from the minor papilla. You can see the major papilla. Now we just did a pre-cut, so we extended the sphincterotomy over the stent with a needle knife a little bit to ensure effective sphincterotomy. And this marks the first stage of this procedure. Patient will be called in after 3 months for repeat endotherapy. You can see on fluoroscopy